Hello, everyone, and thank you for joining us for today's webinar. I'm Dave Iverson, the Michael J. Fox Foundation's contributing editor and the moderator for today's Third Thursday webinar on Parkinson's psychosis. As many of you know, no doubt, this is part of our ongoing Third Thursday webinar series that takes place the third Thursday of each month at 12 o'clock Eastern, 11 Central, 10 Mountain, and 9 Pacific, where we take up an important topic in Parkinson's disease each month. And so we hope you'll continue to mark your calendar and join us each month. And a reminder that if you are unable to join us live, you can always take in these webinars on demand at any time you like. As always, you'll be able to submit your questions throughout the hour, and we will take those questions in the second half of our webinar today. There's the little Q&A box that you'll see in the middle of the screen, and so you just want to type your questions in there, and we will do our best to get to as many of those questions as we can in the second part of today's discussion. Also, the slides from today's webinar are available for download, so there's a little box again on the screen that says resource list, and so you can click there, and then that document will open in a new browser window, and you can save or print from there. So let's get started with what we're going to be covering on today's webinar. Let's first meet our panelists today and who's going to be part of things. Our panelists include Drew Baru, who is the husband of someone living with Parkinson's psychosis, and Drew will be able to offer a kind of first-person perspective. Joining us as well is Dr. Jeffrey Cummings. He is the director of the Cleveland Clinic's Lou Ruvo Center for Brain Health, and Dr. Cummings, importantly, was also the principal investigator for a new drug to confront Parkinson's psychosis that we'll be talking about later in our webinar today. And joining us as well is Dr. Rachel Dolin. Dr. Dolin is a movement disorder specialist, and she's here on the staff of the Michael J. Fox Foundation, where she is vice president of medical communications. Let's also take a moment to review what it is that we want to be covering on today's webinar. We're having a bit of trouble, there we go, on our slides. We're going to talk about what Parkinson's psychosis actually is. It's kind of a scary word, I think, just in and of itself. And so we want to talk about what it is, what it isn't, and most importantly, what it means within the context of Parkinson's disease. What does it mean to have Parkinson's psychosis? Also want to talk some about where it comes from. Is it part of the disease? Or is it rather something that is triggered by the medications we use for Parkinson's? Or does it come from both? We will be talking about that. We're going to talk about how you treat this particular symptom. In the past, this has always been a particularly difficult symptom to treat because the very drugs that can perhaps help with Parkinson's psychosis sometimes have a not great effect on the rest of Parkinson's disease symptoms. So frequently people with this symptom have been kind of stuck in a catch-22. Fortunately, though, there is a new therapy that's just out that offers a different approach. And so we'll be spending a lot of time talking about that new therapy and what in particular it offers. And then finally, we're going to spend some time talking about Parkinson's psychosis from a family point of view and what people in a family can do in order to be able to support their loved ones best of all. All right, let's get started with what it is that we're trying to accomplish in our overall webinar today. And we're going to begin by talking a little bit about what exactly Parkinson's psychosis is. And you see the kind of listing of the different symptoms that are part of this. And Dr. Cummings, let me start with you and have you describe, if you would first, what hallucinations actually are. Someone's already written in saying, well, are hallucinations the same as nightmares? So describe what we mean when we talk actually about a hallucination.
Yes, thank you, Dave. Thank you for the introduction. Hallucinations are the experience of seeing something, usually a fully formed animal or person that is not there. And a common situation would be going to bed at night, there are low light circumstances, and Someone has the experience that there's someone standing there in the room, usually silently. Might be somebody that they know or someone that they do not know. One of my patients, for example, looked into the back seat of the car and said, "Why are those children there?" But there were no children in the back seat of the car. So they're fully formed, often very compelling. Sometimes the patient knows that they're not real, that they're false visions, and sometimes they don't. Delusions are false, often paranoid beliefs. Again, just to use an example, one of my patients believed that as he was walking down the street, that the street lights were actually following him and focusing on him as he went from street light to street light. So, of course, he felt like he was being watched, and he felt like these street lights were under the control of someone who was following him and shining the light on him as he went along. So you get that sense of, well, he believed that, it was untrue, and it was paranoid in the sense that he thought someone was watching him. Illusions, they're a little bit like hallucinations, but they're misinterpretations of things that really are there. Again, I'll give you an example from my own patient experience. I had a patient who was near a road, and as he lay in bed, the lights from passing cars would reflect on the ceiling. And that was the perfect situation to misinterpret those lights coming by. And he would see all sorts of movies and images projected onto the ceiling, and it was really the misinterpretation or the illusionary interpretation of the lights coming from below. And finally, there's the false sense of presence. That is the feeling that someone is nearby, especially behind you, and there's really no one there. But it's a sense of, wow, someone is right here with me and looking back. And so these all form hallucinations and false beliefs that occur in the setting of Parkinson's disease.
And Dr. Dolin, add one aspect to that, if you would, about delusions in particular. Dr. Cummings gave the example of thinking that, street lights are following you and having a kind of paranoid sense about that. But as I understand it, these sorts of delusions can also be the kind of thing where you start holding fast to a false belief about perhaps your spouse or partner, so that you believe that they're not faithful or someone's stealing from you. Is that also the kind of delusion that people can have when they have this sort of psychosis?
Yeah, so commonly delusions do center on spousal infidelity, the sense that somebody could be poisoned. Maybe they don't want to take their medications because they think they're being poisoned. Financial matters, they think they're being stolen from. But delusions are fixed, false, firm beliefs that people just cannot be convinced otherwise from. So you could try as much as you want to rationalize with them, but they just cannot be convinced that these are not true.
And let's also spend a moment on the point that's highlighted under the title of this slide, which is, I think, eye-opening, where it says that more than half of people with Parkinson's may at some point experience one of these things that both Dr. Dolin and Dr. Cummings have been describing. So Rachel Dolin, first, do we know who does this happen? I assume later. Is it commonly something that happens in later stage disease? So when we say it can occur up to half, that's happening later on, not early. Is that correct?
Well, that's true. Like you said, it's eye-opening and it's scary that potentially half of people with Parkinson's could experience one of these symptoms. First of all, we know that hallucinations and delusions are the most common of the symptoms of psychosis that could happen in people with Parkinson's. They're not going to happen in everybody with Parkinson's, and they are going to be more common with longer duration of disease, so in later stages of Parkinson's disease, people who have more severe symptoms of their Parkinson's disease. We also know other things that can go along with psychosis, things like cognitive impairment or memory or thinking problems, especially if that's more severe, where we would call it dementia, when it significantly impacts daily life. And then things like older age and other impairments like mood problems, sleep disturbances, even things like visual impairments that can affect and cause psychosis or contribute to psychosis.
And Dr. Cummings, how able are we at this point, as someone who sees patients all the time at the Cleveland Clinic, to have a sense of whether or not someone may be headed for this kind of problem? Do you have is there a way of telling earlier on in the disease who may be more at risk for this particular problem?
I thought, Dave, that Rachel did a good job of outlining some of the risk factors, particularly failing memory and more impairment with cognitive aspects of life, and more disability is associated with the increased likelihood of developing them. And then there is a kind of progression from a sleep disturbance, and I thought it was very interesting that one of our questioners asked about the relationship of sleep and hallucinations, or dreams and hallucinations. So it is common for people to have increasingly vivid dreams, and then hallucinations, and then delusions and hallucinations with being completely convinced that the delusions are true. So when we start to see someone who's having very vivid dreams and it represents a change from their previous state, that's a person that we start to be very vigilant in terms of the emergence of hallucinations and delusions.
Let's then move to talking a little bit more specifically about how this winds up actually impacting people in their daily lives. And we want to bring into our conversation now Drew Baru, who, as I mentioned in the introduction, is someone whose spouse, Nora, does suffer from Parkinson's psychosis. Drew Baru, thanks very much for being part of our conversation today. It's a really important and valuable contribution for you to make, so thank you for that. If you would describe something about what your experience has been. I know Nora was diagnosed with Parkinson's in 2001, as I recall. These symptoms first cropped up 10 or 11 years later. Tell us something about your story and how they first came to be, and what it is then, describe the way in which that's impacted both of your lives.
Thanks, Dave. I became aware of this problem only when Nora had it. That is, I was not aware that Parkinson's psychosis even existed as a problem. In 2012, we were flying back from Seattle, and it was a stressful flight. And later on that day, after we had gotten home, my wife walked into our family room and said, "I came to join the party." And I asked, "What party?" And she said, "Well, all these people." And of course, there were no people. And that was my introduction. I didn't know what was going on. Other symptoms she had, I lost her at one point. One night I came up from my office and I couldn't find her in the house. It was winter, it was cold, and I found her sitting in the car with the door open in a nightgown, bare feet, and I said, "What are you doing here?" And she said, "I'm waiting for you to take home the people in the back seat." Of course, there were no people. And it just got worse from there. She would talk to plants. She was yelling one day at a plant. Eventually, I put together that when she said she saw green-haired people, what she was seeing was hanging plants. So we ran the whole gamut of hallucinations, illusions, waking up from dreams, thinking she was going to be killed. And I frankly didn't know what to do. I was exhausted. It was hard for me to sleep. And then we heard about the study for Nuplazid, and we got in that study. And some weeks later, those dreams, those hallucinations were just gone. Now, initially it was a double-blind study where we didn't know if we had the drug, but it became very clear very quickly that indeed she was on the drug. And since then, it's been much better. She still occasionally sees people, but she's no longer afraid of what she sees, and she knows they're hallucinations or illusions. And so our life has gotten a lot easier and calmer.
We're going to talk more about the new drug that you just mentioned, which Dr. Cummings was the principal investigator on researching and what it does and why it's important that it's now soon to be available. It has received FDA approval. But before we get into all the treatment options that are out there, I want to spend a little bit more time just talking about the problem itself and where it comes from. And first ask Dr. Cummings, if you would, to just listening to Drew's story. And it sounds like that Nora really experienced almost all of the symptoms that you and Rachel were going through before, not only hallucinations, but also illusions and delusions. Is that common, Dr. Cummings, for someone to sort of get the full collection of symptoms, or is it more typical to have one or the other, but not all?
Drew, thank you for that really insightful description of your wife's illness, and of course we're all sorry that she has this illness. And I would say she was unusually florid. Florid is a word that we use to describe the syndrome when it has so many components to it. So it is common to have hallucinations and delusions, but Drew's wife had so many delusions, so many hallucinations, so many illusions that she is a sort of a more extreme example of what can happen in Parkinson's disease psychosis. But certainly she just represents one end of the spectrum, and it's not so different, just more severe than what other patients are likely to experience or to report.
And Drew, did Nora's symptoms start in the way you described after that long flight home, and it almost seems like it appeared in sort of full-blown form, that it wasn't something, we often talk about the progression of Parkinson's symptoms and how they increase perhaps over time. It seems like in your experience it started at 100 miles an hour.
At least 100 miles an hour, yeah. It was just sudden, and there they were. And it just wreaked havoc.
And Rachel Dolin, is it something, one of the questions that's already come in this morning is, can hallucinations go from benign to much more acute in the way in which Drew was describing? I know when you were in private practice that you had some patients who had sort of the more mild kinds of hallucinations. Can it start one way and progress, or what's the pattern that takes place in that regard?
It's hard to say since everybody's so individualized. And as you said, some people can be very mild and have very what we would call benign and have insight into them and know that they're a hallucination. I had one lady who would tell me her little Japanese figurines on her bookshelf did a little dance every night, and that didn't really bother her. And then I had another patient who was, calling the cops every day because he thought there was a burglar coming in. And obviously that was very disruptive to his and his wife's and his society's life. But, when somebody has more benign hallucinations, you would hope that they would stay more benign, and you would try to keep them more benign by, managing medications, managing their Parkinson's disease. But certainly they could progress as the disease progressed, and so you would want to do your best to manage medications and manage their Parkinson's disease to try to keep them as benign as possible or as mild as possible.
And again, in just a moment, we'll get to some of those treatment choices and options and talk in more detail about the drug that Drew Baru mentioned that his wife participated in on a trial basis, and that seems to have made such a difference. One more question to you, Drew, before we begin to get into that, and that is if you would describe the impact. The last point on this particular slide talks about how this may contribute to the need for an alternate living situation. You've talked some about how, in our previous phone conversation, about how you've managed this in the home and how you've also tried to get additional help. Can you describe a little bit about the impact on your life and your life together with Nora, and how you've tried to manage that and what you feel you most need in order to manage it going forward?
Well, my situation is perhaps better than many people. I work from home. I write software. My office was in the basement, and one of the impacts was I had to get out of the basement. I had to move up on the same level as Nora so that I could be around all the time, because clearly with the hallucinations, I couldn't very well leave her alone. And we've had to get people to come in and help spend time with her. She's a former foreign language teacher, French, German, and so she relates well to students. And one of the things we did is we had gotten some students that would come in and sit and be with her, just to talk with her and just to interact with her. That helped a lot. But the main thing is that you just have to find a way not to leave her alone, because you can't predict when these symptoms would occur. P-Pod for food delivery became a really good idea. Now she goes to a Parkinson center 3 days a week, and those are the days I have to race out and get food, because it's hard for her to get around the stores anyway, and I can't leave her at home. So it becomes difficult.
Right. Well, thank you again.
Dave, I'd like to make one point. Dave, could I make one point, too, that occurred to me, and Rachel touched on this, but I thought it would be worth making it overt, is that these are firmly held beliefs when the person has a delusion, and it is usually hopeless for the caregiver to try to talk them out of the belief. If they believe that the spouse is unfaithful, the spouse usually can't convince the person through logic. You know, when I went out yesterday, I wasn't going to meet someone. You saw me come back with the groceries. You know that our daughter was with us. That kind of logic never seems to impact these beliefs. So it's better just to acknowledge that they are not true, but then go on to the next thing, because the idea of engaging in a conversation, of trying to talk the person out of the belief, just is not a worthwhile experience.
A really important and useful point. Let's push on and talk some about sort of the nature of this problem, where it comes from, and that will lead us into the treatment options that are both have been available and will soon be available in terms of this newly approved drug. And you see this slide that's titled, "Is it a symptom, or is it something that happens because of medication?" And the answer is both. And this is sort of the dilemma to date. If you would give us a little bit more sense of that, Dr. Cummings, that one of the problems has been that normal antipsychotic drugs don't have the best impact on Parkinson's disease, and in fact, some of and similarly, Parkinson's drugs themselves may exacerbate these conditions. So it's been a real dilemma. Describe a little bit more about where the psychosis comes from and the role that drugs play in either a helpful or hurtful way.
Yes, thank you. Great question, and one that I feel we do not have complete answers for. What we know is that hallucinations can occur in Parkinson's disease without any treatment. So it can be a part of the disease, and particularly in the syndrome of dementia with Lewy bodies, which your audience may have heard about, where the cognitive impairment occurs first, and then the Parkinsonism. In that setting, hallucinations are extremely common and well before medication is introduced. In the typical case of Parkinson's disease, it is common for the hallucinations and delusions to follow treatment with anti-Parkinson's medications such as Sinemet that many of your audience may be familiar with. So there does seem to be an interaction between the disease itself and the treatment, so both of these appear to be playing a role. The medication dose is not particularly well correlated with the occurrence of these. So it's more like it's a permissive factor or another risk factor that gets added to the treatment of the patient, and then the hallucinations and delusions emerge. So this is a complex interaction involving both the brain disease itself and the treatment of the brain disease.
And Dr. Cummings, a number of people are writing in about something you just referenced, which is Lewy body dementia, which is something that can exist as part of Parkinson's disease or precede it or exist independently. And they're wondering if the hallucinations that are associated with Lewy body dementia, or LBD as it's sometimes referred to, are different than what we're typifying today as Parkinson's psychosis. So are they two different kinds of hallucinations, or are they interconnected?
Well, I'd appreciate Rachel's comment on this as well, but from my point of view, I see absolutely no difference in the kind of hallucinations that my dementia with Lewy body patients experience and those reported by Parkinson's disease patients. So I think that this is, I believe it's really very much the same kind of syndrome, and with the patients having the same kind of experience. The dementia with Lewy body patients often have more cognitive impairment, so they may have less insight into them than the patients with Parkinson's disease. But overall, they're extremely similar, if not identical.
Yeah, and I would say exactly the same thing, that the hallucinations would be of the same character. It's just that I would stress, like you just said, Dr. Cummings, that typically how we differentiate this as doctors at the current time is we would typically diagnose Lewy body dementia when the symptoms happen earlier on in the course. So if the hallucinations and the memory problems and maybe some problems with attention and concentration and things like that are happening earlier on in the course, like in the first year of the symptoms of Parkinson's disease rather than later on.
Let's turn our focus now to treatment and talk about how some of these how it's been treated typically in the past, and then that will carry us into the new drug that we want to focus on. Rachel Dolin, we have at the top here that there are some things that people who are in this situation ought to contend with first, like make sure there's not a problem with dehydration or infection. But then there's this next point, which is something I was alluding to a moment ago about the role that Parkinson's drugs can play, and Dr. Cummings was talking about that some of the drugs we use in Parkinson's disease seem to exacerbate symptoms. What's going on with that, and what might people want to do or consider doing in terms of reducing perhaps their Parkinson's medications to see if that'll help with these psychotic symptoms?
Well, the large majority of medications that we use in Parkinson's disease work on the dopamine system, because dopamine is the brain chemical that pretty much goes missing in Parkinson's disease. So we try to replace that or replenish that chemical with our medications. By increasing that chemical, we can exacerbate or contribute to psychosis. So when those symptoms arise in the course of Parkinson's disease, we may try to adjust medication to lessen psychosis. The problem comes in that when we may adjust medications, we might worsen the symptoms of Parkinson's disease that we are treating with our medications. So if our medications are helping our motor symptoms, our tremor or our stiffness or our slowness, and then we decrease or remove our medications in order to treat psychosis, we may then worsen our motor symptoms. Our tremor may get worse, or stiffness or slowness may get worse. So that's kind of that catch-22 that you alluded to earlier that we've been in with our treatment.
And that's further been compounded by the typical standard kinds of antipsychotic drugs that's referenced here on the screen, that they compound things further because of the way in which they impact the dopamine system?
So previously, the antipsychotic medications that we've used, if we've gotten in that position after we've looked for reversible causes that you mentioned, and we've tried to adjust the Parkinson's medications, and then we've gotten to the point where the psychosis is disruptive to the lives of the person experiencing it and their caregiver or their families. And we've gotten to that point, we've had to prescribe an atypical antipsychotic medication, and we do this off-label because they're not specifically indicated for Parkinson's disease psychosis. So we've tried Seroquel, you can see on the screen there, or Clozaril. These medications are typically used more for thought disorders like schizophrenia or other mood disorders. But again, we use them off-label, balancing the side effects versus the benefits. Clozaril, for example, has a side effect where it can lessen the infection fighting white blood cells. But these medications work against the dopamine system as well, so they can worsen those motor symptoms just like I was talking about. So again, you're in this balance, in this catch-22, where you could be treating the psychosis symptoms but potentially worsening the motor symptoms.
And that brings us to where we are now in this new drug, Nuplazid or Nuplazid, apparently both pronunciations are used, that was recently approved just a few weeks ago by the FDA, which works in a different way, on a different neurotransmitter. So take it from there, if you would, Dr. Cummings, since you've been so intimately involved in this drug, and we'll talk more about what it is and how it works, and then we want to get Drew's perspective again on how it's been useful for his wife, Nora, in particular.
Yes, thanks. So Nuplazid has a absolutely fascinating biography, and it was discovered because antipsychotics, like the ones you see listed here of Seroquel and Clozaril, are very complicated drugs, and so they affect many different kinds of receptors in the brain. So some clever scientists looked and said, well, what do they share? What is it that all antipsychotics share? And maybe that's the key to treating psychosis. And when they looked across the profiles of all these antipsychotics, one receptor stood out, and that was the serotonin 2A. So this is how we label things, by numbers and letters. So this was the serotonin 2A receptor. And it was affected in all of the antipsychotics that were studied. So, of course, then they concluded that maybe that is the critical receptor for the treatment of psychosis. And fortunately, it is not the dopamine receptor, which, when we treat it, worsens the Parkinsonism. So a drug was developed, pimavanserin, which is a blocker of the 5-HT2A, the serotonin 2A receptor. So it was really a very cogent, structured scientific search for this one receptor type, which we thought would be useful because it was the one receptor that was affected by all of the antipsychotics that had been studied.
And Drew Baru, let's come back to your story at this point. And once Nora was part of the study and was taking the drug, describe the difference. Obviously, I'm sure it did not make everything better. I know Nora is challenged by other symptoms as well. But in terms of this particular issue of psychosis, be they the hallucinations or the delusions or illusions, describe how your day is different, I guess, when Nora is taking this drug.
Sure. Now that she's on the drug, initially the symptoms all went away. She had no illusions, no hallucinations. They were just gone. But over the years, they have slightly crept back, where she will occasionally see things. But the difference is she knows they're illusions. And if you say to her, nope, there's no person there, she accepts it. Before, she was convinced that they were there. Then I don't want to say they're lighter, but they're the difference between a fully formed being and a ghost, you know? I mean, they're sort of there, you know? That alone has made it much easier.
Yeah. Let me just interject for a moment before you go further, Drew, and ask Dr. Cummings to describe in your research and in the clinical trials with Nuplazid or Nuplazid, whether or not what Drew was just describing has also been something that you've observed. You made the comment earlier that there's kind of no point in trying to convince someone who is holding on to a particular delusion or that it's not true. Drew is suggesting that in Nora's case, at least, that she accepts now a different, when Drew says no, that's not correct. Is that more likely to happen with a hallucination as opposed to a delusion? And can the drug be helpful in having a person, I guess, accept a different version of reality?
So Drew's just a great observer, and his subtlety of observation is far more than we are able to measure in a clinical trial. So we used an instrument called the Schedule for Affective and Psychotic Symptoms, PD, modified for Parkinson's disease. And what we showed was a very robust, statistically significant, and clinically meaningful reduction in hallucinations and delusions. And we used both the summary score of hallucinations and delusions, and we analyzed it independently, that is, on both the hallucinations and the delusions independently, and we had very robust reductions on both of those. We also had a significant reduction on the global scale, which is another way of thinking about the way the patients are affected by the disease. And then we had a caregiver rating, and it was also significantly improved in the patients who were on the pimavanserin or Nuplazid compared to the placebo group. So what we used was a scientific scale because we're not able to capture these nuances that Drew described so well, which is the difference between the sort of the soft hallucination versus the hard hallucination. And so we had a rating scale which has been proven to be useful in measuring hallucinations and delusions, and the outcome of the trial and the approval by the FDA was dependent on that scale.
Let's start taking all of your questions, many great questions coming in. So we want to talk more about what caregivers can do in particular, and Drew's view on that we will get to. But let's start taking some of our questions. One of them that has come in now is about side effects. Dr. Cummings, every drug we take, of course, has side effects. There's no free lunch. This particular drug does come with some warnings. So tell us something more about that and about the side effects that can occur when you take this particular drug.
Yes, thank you for that, and thank the audience for the question. This is so important, and it is true, just as you said, that there is no drug that we know of that does not have any side effects. And if we knew such a drug, it probably also would not have an effect. So here's the main worry that we're going to be talking about as we work with this agent is. It was still classified as an atypical antipsychotic by the FDA. So it's still viewed as to belong to the class of antipsychotics because it does reduce psychosis. Now the FDA has learned, looking at other antipsychotics, that the risk of death of patients is increased by treatment with antipsychotics. It goes up from about 2.5% to about 4.7% in people who are on antipsychotics compared to those who are not. This applies to elderly patients with cognitive impairment, including Parkinson's disease. And so the drug has a warning that says there is a chance of mortality if someone is treated with this agent or other antipsychotics. All antipsychotics bear this label. Now, we did not see any deaths in our clinical trial. So we think that eventually this warning could be reasonably reconsidered. But given the history of this class of compounds, the FDA always wants to take a conservative route and to let people know that this could occur. And so there is a warning for mortality associated with pimavanserin. There were two other symptoms that we're seeing at increased frequency. One was swelling of the feet, and the other was confusion. So about 3% of placebo patients became confused, and about 6% of pimavanserin patients became confused. So there was an increased incidence of confusion. We don't really understand that yet. We're watching it in the studies now that follow, and the same with the peripheral, the swelling of the feet. We're not sure why that happened, but we're seeing whether that will be seen in other trials that are ongoing now.
And Dr. Rachel Dolin, I think this is a question that comes up really with any condition, but with Parkinson's in particular, there's often an assessment you have to make about risk and benefit. That could be true whether you're thinking about undergoing deep brain stimulation or starting a particular drug. There are always kind of pros and cons, risk and benefit to weigh. I'm just curious about how patients ought to think about those equations. As Dr. Cummings was suggesting, it's true of all antipsychotic medication that risk may go up from 2-point-something% to 4%. But I imagine you also have to weigh into that what the benefits are going to be. How would you suggest that people make that sort of calculus?
Yeah, just like you said, no medication comes without the potential for side effects, but they also have benefits, which is why we use them. And so the situations in which we're considering these medications are ones in which the psychosis is posing a risk for patients and their families, disrupting the lives of patients and their families. And so those are the types of situations that we are weighing the risks versus benefits. And so I would suggest, having careful, considerate conversation with your personal physician about what is the situation at home, what are the hallucinations, the delusions, how are they impacting the lives of the patient and the caregiver, and what could this medication potentially offer in the way of that? What would be the expected benefit and what would be the possible side effects?
Drew Baru, anything you'd like to add in terms of how people can, from a caregiver's, spouse's perspective, kind of make that decision about the risks that are involved in comparing that with the benefits that can accrue?
When the psychosis is so bad that living is painful for the patient, I don't see how you don't try the antipsychotic. And in the case of Nuplazid, it made her life so much better that it would be criminal not to have her take the drug,
Yeah, well put. Thank you. Let's take more of our questions that are coming in, and here's one that applies to the slide that you see now on the screen about how people can do well with this condition in terms of how they interact with people there. And one of the questions that I'd like to get to is, so what do you, if people aren't able to talk well or help their partner realize that a delusion isn't worthwhile, this person asks, is there a better technique that you might be able to use? Should you move on to the next topic? Do the people experiencing them want to push on to talk about the validity of their experience? How do you change topics without being dismissive? It's a complicated arena. And your suggestions on that, Drew, when Nora was having these, and still has to a degree, these symptoms, what do you suggest in terms of how you respond to them without being dismissive of them?
I'm interested in the word dismissive because I guess when I say, no, that's not real, it is sort of dismissive. But I've always been honest with her. She had the situation of looking out her window and seeing deer outside our window. Now, we live on a wooded property. We're about 300 feet from a road, so it's possible. I would look out, no deer. So I'd say, there are no deer. This went on. And one day, driving in the driveway, there in our circle, right outside her window, 3 deer. So it makes it very hard for her to know what's true and what isn't true. And the only thing I could do was just to always be honest with what I saw.
I think, Dave, a transition might. I really liked Drew's discussion of hanging plants, which Nora saw as people with green hair. And I think you could do a transition like, I see people with green hair. No, Nora, this is really a hanging plant. I see these plants need watering. Let's go get the watering can and water these plants. I see they need that. So you've acknowledged the truth, but you haven't tried to talk her out of it, and now you've transitioned to the next thing that you can do together and try to get sort of away from that situation. Yeah,
well put. Rachel?
I was just going to say, just like you had mentioned earlier, Dr. Cummings, I think, figuring this out together, figuring out what works for you and the person who has the hallucination or the delusion, but not arguing because that gets you nowhere. So not saying, nope, there's nobody with green hair here, but, just, maybe acknowledging and figuring out how to move on to the next thing. But I wanted to point out, as you had earlier as well, Dr. Cummings, about, environmental triggers, those lights coming into the room and triggering a hallucination for a patient. But I think something that we need to pay attention to for a lot of people, especially as we get older, are vision and hearing impairments that can trigger or contribute to hallucinations. So making sure that somebody's got their glasses or their hearing aid, and that we take those things into account that are easy things to make sure are there.
Really useful points. A question, Dr. Cummings, about the mortality risk that you referenced earlier. Again, this is with all antipsychotic drugs, that there's a bump up in mortality from I think you said 2.5% roughly to 4%. And the question is, death from what? So how do these antipsychotic drugs create an additional risk of dying? What is the risk that happens? What is the cause of death that occurs?
Yes, thank you. Good questions. And I wanted to correct something I said earlier, because I said that there were no deaths. There were actually 3 deaths in the study, 1 in the placebo group, 2 in the pimavanserin group, and none of them were attributable to the drug. Okay. I meant that no deaths occurred that were attributable to pimavanserin. And the deaths that occur with antipsychotics seem to be the things that people with neurological disease generally succumb to, which is heart disease and pulmonary failure and infection. And there was nothing outstanding about it. It was just that more of these kind of natural causes, if you will, occurred historically in the antipsychotic group compared to the placebo group when they looked across many, many studies. So there wasn't something that was outstanding about it. It wasn't as if they induced a stroke or that they caused a seizure that the person died from. None of that happened. It was just the things that occur in the course of a neurological disease that people succumb to when they have a neurological disease, but they occurred slightly more frequently in the antipsychotic group.
I see. Drew, here's a question that I'd love you to be the first responder to, which is this person raises the question of the social stigma that comes with psychosis and wonders, how do you go about talking about this with other people in the family or with friends? How have you approached that?
I've always been really open, and so has Nora. Um, we neither of us see it as, something she should be ashamed of. It's a disease. And so we just talk about it. If somebody thinks poorly of Nora, well, maybe that's a person we don't need in our life. But we've just been very, very open. People ask, we talk about it. People don't ask, we talk about it, because it's such a major part of our life.
I don't think you could have a better answer than what Drew Baruch just did. But anything to add, Dr. Dolin or Dr. Cummings? Dr. Dolin first.
Yeah, I would add just what Drew said, is that this does not mean you are losing your mind or you are crazy. This is part of the disease. It's the medications we use to treat the disease. And if you don't say something to your doctor, to your family member about it, then we can't do anything about it. So I hope that this raises awareness about this symptom and that we can have an open conversation about it, because just as Drew said, this does not mean anything about your character. This means that this is part of the disease and, again, part of the medications that we use to treat it, and there are things that we can do about it.
Dr. Cummings?
I would just amplify all those messages. I think these have been really great, that we need to educate people that this can be part of the disease and part of the therapy, and it's nothing that means that they're going crazy. I think that's a common fear that people have. I also, in my own speaking with patients, I talk very specifically about hallucinations and delusions, and I tend to avoid that word psychosis, because I think psychosis is a confusing and loaded term, and we're really worrying about these two events that people are having, hallucinations and delusions.
Yeah. Question coming in about Dr. Cummings about when in the course of PD psychosis or Parkinson's in general, later stage Parkinson's, should people start taking Nuplazid or Nuplazid? In other words, I guess, is this something that you should only take if you're dealing with these symptoms and they're making a harmful or having a harmful effect on your life? Or I wonder if people are also wondering if there could be some preventive or prophylactic benefit of taking this drug.
Yeah, what a great question. I can see that we have just a terrific audience listening with us today, and that's the scientific question actually we're interested in. So at this point, the use of Nuplazid is triggered by the presence of delusions and hallucinations, which are disturbing to the patient. Again, there are some benign hallucinations, and we don't think that should be treated. But when these hallucinations and delusional experiences begin to interfere with the patient's life, we believe that they should be treated. And I described earlier how there's a kind of evolution from extreme dreaming into hallucinations and into delusions. And I think one very important unanswered scientific question is, if we intervene early, can we prevent people from having these later, more severe symptoms? We don't know the answer to that yet, Dave. So at this point, we use it to treat the symptoms when they become disabling for the patient.
Eric asked whether or not it takes a while for Nuplazid to build up in the system in order to take effect, or does it work really quickly as soon as it's taken? Drew, again, your experience was that the impact was almost instantaneous. Is that right?
Well, it was over let's say, a period of a month that at some point it dawned on me that Nora was no longer seeing things. But I'd like to make one comment. I had said earlier that I did not know that this was part of the symptoms of Parkinson's disease. But that was back in 2001 when I did a lot of looking. I did looking yesterday and again this morning. I did Google searches for Parkinson's disease symptoms. Not one site mentions Parkinson's disease psychosis as a symptom. I don't understand that.
It sounds like we have some work to do in terms of our education about that, and perhaps even from foundations like our own and others, to make sure that people understand that, as both Rachel Dolin and you have said, and Dr. Cummings as well, that it is part of the disease, and it's healthy and helpful, I think, if we can look at it in that way. So thanks for the making that point as well. Dr. Cummings, any other thoughts on the rapidity with which the drug works?
Yes. So in our trial, we had measurements at day 15 and day 29, so at the end of 2 weeks and at the end of 4 weeks. At the end of 2 weeks, there was a definite improvement, but interestingly enough, there was also an improvement in the placebo group at 2 weeks. At 4 weeks, there was a much more robust improvement in the pimavanserin or Nuplazid group compared to the placebo group. So in our study, we can see that at 4 weeks we have a clear separation. At 2 weeks we have improvement, but it seemed like everybody was getting better in this particular trial by 2 weeks.
A question about violence. Does violent acts, I guess, ever accompany these sorts of hallucinations? I suppose it depends on how you define that. Certainly it's possible to perhaps for the patient to undergo harm. Your story, Drew, about Nora going out to the car in the middle of winter. But what about that, Dr. Cummings, and just as people can harm themselves if they're suffering from REM sleep behavior disorder, are there concerns about that, about either doing harm or being harmed yourself?
It's rare, but it is a concern. If you believe that your wife or husband is being unfaithful, you might get into an argument that's unavoidable and would lead to shouting and maybe even hitting. And I think a major concern is firearms. And if you believe that your neighbor is stealing from you and you have access to a firearm, that's not a good situation. And so I would encourage people whose spouse or family member is having psychosis that they are very careful about securing the firearms.
Just have a few moments left in our webinar, and so I want to use those, if I might, to just kind of convey a few last messages, both in terms of the advancement that is now available through this drug. Dr. Cummings, if you would start your comments by not only commenting on what it offers, but when it will be available. It's been approved, but how soon will it actually be on the pharmacy shelves, and when you think it can be, again, the most helpful to people.
Yes, thank you. Well, let me say that I think this is a breakthrough agent, that this is the first drug approved for the treatment of delusions and hallucinations for any neurological disease. And I'm so encouraged that we're starting to seriously develop new treatments for the neuropsychiatric complications that are so frequent with all neurological diseases. So I think I just can't convey my scientific enthusiasm for the direction that pimavanserin represents within our field. Now, I don't work directly with the companies providing this. I've heard that it's going to be available by sometimes towards the end of June or in the summer, but I don't know that for sure. So I'll just tell you that is what I've heard. And then we'll be using it to treat the occurrence of hallucinations and delusions when they're disabling for the patient. And we talked earlier about the fascinating possibility that this might have some prophylactic value, but we wouldn't be using it in that circumstance yet, and it wouldn't be approved for that. It's only approved for the treatment of hallucinations and delusions.
And Rachel Dolin, the last comment from you, both in terms of the takeaway message that you'd like to have people have from today's webinar, perhaps also, if you would, since we didn't talk about this, about cost considerations. We don't know yet a lot about that, but we've listed on links to where people can find out more about getting cost assistance. So a thought on that and what you'd like people to most be thinking about as we begin to wrap up our conversation.
So I too have heard that the medication should be available hopefully in around June. We don't know the out-of-pocket cost for people yet. That'll differ based on people's insurance, but we should know that around June as well when the medication is available. The company that made Nuplazid, Acadia, does have an assistance program. You can find more about that in our resource list and through their specific website, and they have a telephone number you can call to find more about that as well. I believe that is for people who are uninsured or do not have adequate insurance to cover the medication. And then there are certain organizations that provide medication assistance based on need. So there are certainly ways for people to get access to this medication, and cost should not be an issue for people. Or the company does not want cost to be an issue standing in the way of people getting this medication. The takeaways, Dr. Cummings covered those very well. I believe that this is a real representative step forward in the Parkinson's field. We are addressing unmet needs for people, I hope, and this is a non-motor symptom of Parkinson's disease that we now have a treatment indicated specifically for. And just as Drew mentioned, I think we're raising awareness of this symptom and in getting the conversation open and started about it, which I think is really important.
And Drew Baru, the last word is yours. What you'd like people to think about who may be contending with this in their lives, and sort of getting the word out, I guess, further, as you've done so in such a beautiful way, really, as being part of our conversation today.
Well, I encourage people to, you know, if you're the person you're taking care of has symptoms, see your doctor, talk to them, because keeping it hidden doesn't help the patient at all.
With that, we'll wrap up our conversation today. I want to thank both Dr. Cummings and Dr. Dolin for their participation. Particularly want to thank Drew Baru and his wife Nora for telling their story and opening up this important conversation to all of us. Thank you all for being part of our conversation today. We'll be sending a link to the webinar on demand so that you can listen again or share with others. There will also be a survey link in the email that we'll send out, as well as in our resource box now. And we hope you'll share with us your thoughts on today's presentation. And then last, we hope you'll join us again for our next Third Thursday webinar. That will take place on June the 16th, where we'll be talking about the problem of both depression and apathy in Parkinson's disease. So we hope you'll join us again on our next Third Thursday webinar. That's all for today's session. I'm Dave Iverson. Thanks for joining us.